All right, so we're incredibly lucky again today to have the rest of our allied health presenters for us. So we're going to have physio and OT, and we'll also be talking about social work and psych as well. So I'll get them to introduce themselves, and then we'll go through the same format.
Hello, I'm Eve. I'm one of the senior physios that works in the area, so I'm from wards.
Okay, and I'm one of the senior occupational therapists that works in the
Great, so if we can get the physio crew up, that'll be amazing.
Cool. So starting with physio, just a little gist about where we are. So we're involved with patients across most of the hospital. So we work in ED on the acute surgical and medical wards, within cancer care and up in ICU, within rehabilitation, as well as MSK outpatients, outreach and community services, and we also service rehab, ED, and the acute areas on weekends, and an on-call after-hours service mainly for ICU and the acute wards. Within those spaces, we complete respiratory interventions, restorative care, vestibular, and rehab, and we work based off independent assessments and formulate a treatment plan based on the patient's presentations and their impairments. So focusing from a functional mobility and rehab point of view, so we see patients who come in with a decline in mobility or function, and that's compared to the patient's previous level of mobility. So it's always important to know what somebody's normal baseline is, and trial function before referring. So we should, before referring to physio, you should know if they're off their baseline or not, and not just assume. Those that have reduced exercise tolerance compared to normal or previous, but keeping in mind those guys are lower on our priority list to see than others. Those that have come in for a mechanical fall or history of mechanical falls as well. Those that need mobility aid prescription if identified decline in function or to facilitate safe, effective and timely discharges from hospital. Those that come in with new acute neurological conditions such as stroke all get workup by physiotherapy. And generally those that have a decline in mobility, function and or balance secondary to degenerative neurological conditions. What we can't do is we don't see people just for mobility checks or clearance before discharge. So we don't have a blanket rule across all patients or anybody over 75 or anything like that, that we just see them just because. We don't just do assessments for postural blood pressure, so that can be done by the nursing staff or by doctors or others. And from an acute patient perspective, we don't address any long-term chronic issues. So that's, for example, people who come in with chronic shoulder pain or those types of conditions. That's generally a referral to outpatients or community. From a respiratory point of view, we see patients with compromised ventilation, those that have sputum retention, poor cough due to weakness or pain, respiratory muscle strength, endurance, particularly guys coming out of the ICU, and anyone that's got chest x-ray changes linked to the above indications. What we cannot assist with is, again, chest checks or clearance prior to discharge, pleural effusions or fluid overload, just checking people for desaturations and mobility, and giving out incentive spirometers or other respiratory equipment, unless otherwise indicated. Very briefly, from a vestibular point of view, we see patients that come in with suspected peripheral causes of dizziness, such as your BPPVs, those that have which are lasting only seconds or minutes after completing provocative movement, or again, vestibular neuritises from a mobility point of view to make sure that they're safe on their feet before they go home.
So like I said, I'm Caitlin. I'm one of the occupational therapists here. I work full-time in ED. We look at a patient's ability to function in their own environment. So we're looking at who they were before coming into hospital, so before the incident or event, what they're capable of doing and how we can help get them back to the things that they need to do or want to be able to do. So that's looking at their physical and their cognitive function. To do that, we're working towards a safe and a sustainable discharge. So when we discharge someone, we want to make sure that we've put in clear recommendations for them to remain at home and prevent that rate of readmission. We will be looking at their social environment, their home environment, and what they were doing before. So think about it as the person, the environment, and the occupations that they do from a day-to-day basis. For people that are in hospital, most of their occupations would potentially be compromised. So you could even be looking at their independence with toileting, dressing, showering, all those things that they have to be able to do independently to manage at home. Not only do we work across acute, rehab, and community, we also have a new service in ED. It is 8 till 6 p.m. every day. It's a week on, week off roster. So we have another colleague that does the second week to my counterpart. We look at equipment prescription, service provision, and home modifications to our functional assessments. So if we feel it necessary for them to have a specific equipment piece, we would be recommending that before they go home, because we all know that people perform better in their own environment and familiar environments. So what we do see is people that are presenting below their baseline occupational performance, whether that be physical or cognitive. We can do functional cognitive assessments and looking at how they manage those daily tasks. Conditions that impact on ability to safely and independently complete those self-cares. We also have a team in palliative care. We prescribe equipment as well as service provision that needs to be implemented to help with their change in function. What we don't see is physical or cognitive decline expected to improve once they're medically well. NDIS participants that have no change in their care needs. We don't do referrals purely for a baseline cognitive screen. You guys can do that. And patients that are snapped to maintenance or requiring nursing home placement. The same as physiotherapy, we don't get involved with people that just need a clearance for discharge.
So we're going to go through Colin, which I believe is the carryover of the case study from the previous guys. So you know all this bit? Know this bit? Beautiful. So what physio did with Colin. So firstly, we would have gathered a thorough social history and figured out what his baseline level of function was. And then from there, we would have liaised with the treating team around if there's any mobility restrictions given his ischemic toes, and if there's any need for any offloading footwear. Then from there, once we've got some orders around that, completing a comprehensive assessment of his function, his strength, his sensation, and also potentially looking at utilising joint sessions with his daughter and his family if they're available.
We would be looking at his previous physical or cognitive function, so what he was independent with at home and what he currently has. So whether that's any services in place, does he have a current driver's license, is he independently accessing the community, things like that, who is or is supporting him at home. And then we would, with that information, assess the daily activities. So your ADLs, toileting, showering, feeding, whatever is important to Colin, and then doing those further assessments and retraining as indicated.
In the subacute phases, so physiotherapy would progress Colin's function towards baseline or goal function for discharge, and this would include some lower limb strengthening exercises as well as transfer practice to and from a wheelchair, and assisting in the organisation of equipment for discharge, as well as liaising with our other allied health towards discharge planning and follow-up services that may be required.
So you can see there in the picture that Colin's been, given different strategies and different equipment. Think about it from a home environment perspective, your door frames, your circulation space for wheelchairs. Most toilets are separate to the shower. It's not going to fit a wheelchair. So that's where we can go out and have a look at the environment that we're working in and determine what's appropriate to try and identify those problems before they're going home. So looking at equipment, the home environment, and liaising with our MDT members to achieve those goals that are important to Colin. And then we can look at the cognition, communication, and liaising with physio, and we can do joints and reviews as necessary.
So moving on to the chronic phase, so this is more towards the community phase of Colin's care. So physiotherapy and occupational therapy may complete a home visit to assess Colin's function in the home. And then looking at a long-term maintenance program, working towards strengthening and cardiovascular-based interventions within the community setting.
Yep. Like you just said, we work as a team together. we try and problem solve as much as we can before the patient goes home, but we do find that a lot of things, or sometimes it can be information overload for patients in hospital, so they do have a lot of questions about things once they go home, so we try and support them as best we can, and sometimes depending on their goals they might progress and need different equipment, so we just continue to assess and reassess as required.
Any questions for we've got our OT and physio? Go for it.
Yeah.
Yeah. Sorry, the question was about ED role for OT.
So it's a new role. We recently had a HP3 rotational position. That looks at, it's a diverse role, as you know. It could be anything from pediatric burns to head injuries. We do a lot of head injury education, concussion management. Then you could be doing equipment prescription for the frail elderlies that are frequent flyers. They have falls, trying to keep them out or prevent readmission. We also have a lot of those ones that potentially aren't coping in the community but want to stay in the community, so doing home visits as well. At the moment, it's only one OT. I have a lot of plans for the service long term, so we're trying to rely on our colleagues in the community for ongoing assessments and referrals that way. But at the moment, it's just, again, looking at the person and their environment and what they were doing beforehand. So we do pediatrics, burns, adults, head injuries, you name it, we probably see it. Yeah. So I guess, you're looking at the hospital setting as it is at the moment. Sometimes we're bed blocks, we don't have beds. Trying to keep people out at home. People do perform better in their own home. So if it's safe to do so, that would be the ideal and forefront. I guess, discharge planning will be happening day one of admission. So if we can implement these things, meet these people early in ED, start the ball rolling of what do you have at home, what service do you have at home, what equipment do you have at home. If we can be doing that all in ED instead of waiting for them to get up onto the wards, we're already in front. Yeah, come talk to me. We've got just a direct line, just the one phone we carry. If it's after hours, so we're 8 till 6 p.m. If it's after hours, you can put a Red Book referral in. I'm sure someone can show you where that is, or just give us a call and I can come and have a chat. But yeah, our role is quite diverse and it's quite exciting. At the moment, I've got a head injury jockey who's come off, got a significant cut and concussion on the background of a significant head injury with a basic skull fracture. So trying to decipher what's appropriate for him. And yeah, we do a lot of burns at the moment. We've had a lot of with the house fires and cooking with Christmas. So it can be quite diverse, but more than happy to come and chat to me at any time. Give me a call. More than happy.
Go for it.
Can we just grab those? Are they on the ward?
Yeah, they're on the ward. So the incentive spirometry has basically been deemed a low-value healthcare piece of equipment that's been prescribed. Most of the patients that we get asked to give them for are post-abdominal surgery patients. And the evidence within that space is doing deep breathing without the incentive spirometer is just as effective. So we avoid giving out unless it's indicated. Generally, the only indication for the incentive spirometer is rib fractures. So definitely when it's indicated, we do give them out. But if, yourselves decide that you think there's clinical indication for the use of incentive spirometer, they're available on all the wards to be provided to your patients.
An interesting one I know, and again, this have worked on Med 5 before as a pharmacist, and we'd see on that discharge time physio clearance, or how do these guys, because often they'll be the ones who have to, the boss will say, we want this done.
Yep.
Can you give them some strategies to help with pushback, or to sort of, how do they have that conversation? Is it better done just ringing you saying, look, I know you guys can't really, what do I say here? How do you?
I guess it depends. So most definitely if there's a patient that physiotherapy is actively involved with and they're for discharge that day and we haven't yet cleared them for discharge, and when we say cleared for discharge, we mean they meet their goals of being appropriate to manage in their own home. So that might be independent getting in and out of bed, independent with stairs, independent with mobility, plus or minus whatever aid they may need. So those sorts of patients, it's completely appropriate to have a phone call saying, hey, we're planning on discharging such and such either today or tomorrow. We note that they're still having ongoing physiotherapy, just wondering what their progress is. Do you think they're going to be ready by this time? And generally, we will prioritise those patients and make sure that we try to get them ready by that date. But we'll definitely feedback if we think they need like a longer period of time, even though they may be medically appropriate for discharge. The ones that you'll probably get pushback on are the ones that are independently mobile from nursing staff documentation. They're walking to the bathroom, completing their 80 hours independently. Nursing staff have no concerns, and we're not actively involved with them. Those are the guys that we generally won't do just to check for discharge. But if you do some digging and find out that, patients are having falls in the community, and we're talking, 3 falls in the past 6 months, and they're from causes which physiotherapy or occupational therapy might be able to have some impact on. For example, it's not just postural blood pressure related or those sorts of things. Those referrals are completely appropriate, but there's got to be a context around it, and it's got to be something that we can address from an acute inpatient perspective. And sometimes there's checks for discharge where the patients are probably better up followed by a community physiotherapist to check them in their home environment to minimise falls risk there, and potentially not actually an appropriate physiotherapy referral because they've come in for something completely separate to that issue.
We also have a home visiting service. So like Eve just said, it might be not worth seeing them on the ward, but better to be seeing them at home for that falls, for example. So you could even call us and say, hey, this patient's heading home. You don't need to see them on the ward, but they may benefit from allied health services when they go home. That we then can look at whether or not that's appropriate to refer, because we do have a recent expansion in our home visiting service as well.
So I guess the take home is, you've got a question around that, ask.
Yep, definitely.
How sort of is information distributed in the hospital? And if we've got outlines, do we refer to the physio like the ward that we're actually working on? Or
Yep.
do we refer to, say, the ID physio?
Yep, exactly that. So physio and OT staffing is slightly different. So physiotherapy staffing, there should be at least one physiotherapist per ward allocated. Some wards, there's a split ward where, for example, IDW, the IDW physiotherapist also works on Med 4, but they have the same phone number. So generally, best way to refer is phone call. Physiotherapists, from a referrals pathway, we see what's on PFM, but we do our own independent assessments so we'll review somebody's chart, and if we feel the, PT review on PFM is not appropriate, we won't see them, because not necessarily, we don't know who that referral is coming from. So it could come from somebody in ED when the person had low blood pressure and they weren't mobilising, so they've asked physio to see them, or it could come from nursing staff, or it could come from medical. So we don't actually know if those referrals are appropriate. Same with in notes, more than welcome to write, physiotherapy review, but we don't read every chart, so we may not find it. So if you feel your patient needs physiotherapy, just best to call through Switch and ask, can I have the physiotherapist that works on whatever ward, and they'll direct you through, and you can have a conversation from there. And often if you write physiotherapy review within your plan, if the physio happens to be reading the note, they'll just action that straight away if they feel it's appropriate. We won't give you a call and say, hey, we've seen such and such. We just start seeing them essentially. And we're a self-referral service as well. So we see patients that haven't been referred from anybody if we feel it's appropriate for them to be seen.
From an occupational therapy perspective, from staffing, we try and have one OT allocated per ward, but again, that is just dependent on staffing. We do have a senior across medical and a senior across surgical, and then we have rotational HB3s underneath them per ward. It would be the same as physiotherapy, just call and ask for that OT that's working on that ward. You might get a different name, but hopefully that someone can be there for you. And another option would be, we also attend ward rounds.
Yep.
So hopefully you can meet that person there, and we can have that discussion as well. So that might be helpful rather than picking up the phone all the time.
Great, amazing. Thanks, guys.
Thank you.
Oh, beautiful.
Thanks.
Thank you so much. Much appreciated.
Hello, my name's Susan. I'm one of the senior social workers in the hospital here. So I'll just give you a brief overview of what social work actually do. So we are a university qualified profession dedicated to assisting people to improve their lives with a focus on the personal and social well-being. Hospital social workers are working from a medical model informed by social context. Social workers are situated in the healthcare setting for three primary purposes. One is to support the treating team. Secondly, to demystify medical information and processes for the patient, because a lot of the people that we work with maybe have some poor health literacy, so they don't really understand a lot of what is being relayed to them. So we try to break it down into fairly simple terms for them so they have a general understanding. And lastly, we advocate for patients as well. And by advocation, as Caitlin pointed out, I work in ED, so I'll work with Caitlin. Our primary goal is to try and prevent admissions where we can, where it's safe. But sometimes we need to advocate, particularly for elderly patients who won't be safe to return home. So advocate maybe for them to stay overnight in our short stay unit in the ED setting. We are across the hospital, primarily on most wards. We're in the emergency department, we're in women's and children's wards, we have mental health services, we are based in the cancer centre, in the palliative care space. We also have a SPARTA social worker. We're in ICU, we're in the surgical wards, medical wards, rehabilitation unit and the renal unit. So we see patients where there has been a change in the patient's circumstances. We can work with patients to come up with some advanced care planning. We also do case management for those long-term admissions. We can do counselling with patients, adjustment counselling, grief and loss counselling, bereavement counselling. We also talk to family, particularly who are suffering maybe from some carer stress. We can do some counselling there, provide some emotional support. Also emotional support for trauma and crisis. We give families information on the My Aged Care system, NDIS, QCAT and how to access those. We do referrals to external services in the community. We work with patients who come in who are victims of domestic violence. We also do a lot of work around the child protection space. We work with elders and elder abuse. We conduct mortuary viewings and are involved in coronial cases. We also work with patients who are complex discharges, and we try very hard to reduce the risk of patients dying for whatever reason that might be and increase their engagement. We also work fairly closely with the Indigenous liaison officers in the hospital as well. And we support discharge plans with linking people in with communities, particularly with My Aged Care, ACAT and NDIS.
Hi, as I mentioned, I'm Monique, I'm from psychology. I do work in the paediatrics unit, but we do have psychologists all across the hospital. So psychology, who we are. Psychologists study the mind and behaviour. We utilise the science of how people think, feel and behave to support coping and adjustment while they're in hospital. We help people to learn how to understand their thoughts, emotions and how their actions impact how they cope and their life circumstances. So we treat a wide range of psychological disorders using person-centred and evidence-based therapies. So as a psychologist, we complete a minimum of 6 years of study and we are required to be registered with the Australian Health Practitioner Regulation Agency, AHPRA. What we do, so psychologists provide assessment, intervention and appropriate referral options for patients experiencing psychological distress and behavioural difficulties. And this is probably the key part of what we do within the hospital system. It needs to be arising from a health condition, illness or treatment. We provide treatment for people in both an inpatient and outpatient settings, and we work across the lifespan. As I said, I work in the neonatal unit, so sometimes before even babies reach their gestational age, we're already doing intervention. We work across many departments, including chronic disease, which is probably the main part where we work. We work on the medical wards, the surgical wards. We can work with the GERIs, like I said, paediatrics neonatal unit, maternal fetal medicine. So that's with supporting parents with things like complex pregnancies or terminations, podiatry, oncology, endocrine and diabetes. So who we see, so we work with patients who present with a variety of concerns, including depression and anxiety secondary to a hospital admission or medical concern, adjustment difficulties and psychological distress, treatment adherence, needle phobia and panic episodes, health behaviour change, pain management, grief and loss, and end-of-life care. How we help, we provide evidence-based interventions such as CBT, cognitive behaviour therapy, psychoeducation, acute incident psychological debrief and care planning, supportive psychotherapies, arousal reduction, relaxation training, brief assessments, cognitive screeners, and motivational interviewing. Should probably say down the bottom here, and much, much more. Who we don't see. So the psychology department is separate from the mental health service group. We don't focus on the assessment, management or treatment of acute mental health illnesses or concerns that were there prior to the admission. We focus on, like I said, mental health concerns arising from health conditions rather than treating a primary mental health concern. How we explain it to children in the paediatrics department, we work with the big SADs that hospital gives you. Our main purpose and goal is to provide psychological intervention tailored to meet the needs, strengths and current functioning of patients to support best possible health outcomes for them, hopefully limiting readmission. There is evidence to show that psychological outcomes of disease can contribute to treatment adherence issues, increased disease burden and subsequent healthcare utilisation, and increased likelihood of readmission. So our goal is to try and prevent that as part of a systematic approach. So in the acute phase, in the inpatient phase, for our lovely case Colin, who's been diagnosed with Alzheimer's, it may limit his amount of communication around his presenting difficulties for psychological assessment, intervention and consent to treatment. So what we would do would just comprehensive psychological assessment. So we would gather that mental health history, that coping style, the general psychological behavioural function of Colin prior to his admission. We could administer some screeners where appropriate if he does have some insight and ability to complete those. Probably most likely in Colin's case, what we'd be doing is liaising with the family and the treating team and other allied health to gather that collateral information to work out where he is and where he's sitting. And then we would provide, and the key word here is appropriate psychotherapy to manage distress and adjustment. So depending on where Colin sits, if he hasn't got, for instance, good executive functioning skills, we probably wouldn't do something like CBT. We would tailor what Colin needs to his current ability and cognitive functioning, and possibly work with the family to help manage acute distress in Colin.
So in the acute phase or the inpatient phase, social work will conduct psychosocial assessments. We'll also work with the medical teams to try and understand the capacity of the patient, and we will understand preference of care. So we work with families to say, what would you like to do here? Do you think you would be capable of taking this person home and caring for them if we put supports in place? Or is it your preference maybe that this person would go to an aged care facility, and we work on that in the future? So this would involve making sure that there's some advanced healthcare plans in place. There's also EPOAs and a statement of choices. We also attend a lot of family meetings to work with the medical team and the family to reach desired outcomes, and we provide emotional and practical support in the acute phase. And in the subacute phase, you're okay if I go first? In the subacute phase, social work, we understand the support needs and we determine what the current supports are in the home currently, and if they're adequate for this patient to be discharging home. And we can also provide some adjustment counselling, some education on home care services versus RAC going into an aged care facility. We can also talk to the carers about getting some support for them, maybe when the patient returns home as well. We can undertake some case management, and that if someone was going home, case management would be through the community social workers. And we can also continue to work on that discharge planning and being engaged in some family meetings for that to occur.
So for psychology, we would look at how is Colin's admission and health issues impacting his psychological well-being and treatment adherence and engagement with other allied health and the treating team. This is a space we often work in, particularly on the med wards. We'll find people come in, they are motivated, but as the admission goes on, their motivation reduces, and then we see disengagement from services such as physio and OT, which is what they're really needing to get them discharged. So we can go in there, do some motivational interviewing and support patients to try and increase their motivation or willingness to get themselves home. And we do that by addressing symptoms of anxiety and depression. So possible interventions for Colin. So we could provide him ongoing supportive psychotherapy to manage distress and adjustment to what's going on for him. We can provide him with psychoeducation tailored to his current level of functioning and understanding of what's going on. We will continue to monitor mood and anxiety. And we could also provide strategies to Colin, but also to his family on how to support his mental health and strategies to promote relaxation and adaptive coping. So this might be controlled breathing exercises, progressive muscle relaxation and grounding techniques. So in the chronic phase, so in community, for Colin, where appropriate, we could refer him to the older person's mental health team for ongoing support in the community with other patients. We do outpatient services as well, particularly with chronic disease management. With other patients, you could refer to psychology for outpatient support to maintain ongoing health and wellbeing.
Yeah, and if it was determined that further supports are required, we could do a referral to the ACAT team or also a referral to the social workers in the community.
So we have any questions for our social work and psychology? Anything you want to add? Go for it.
Excuse my ignorance, but from a psychology point of view, would you ever see family members of the patient, like in a public care setting or an ICU setting? Would you be able to refer you to see the mother or daughter or father, son of the patient?
Yeah, absolutely. So I also work in the paediatrics intensive care unit, and that's primarily where my role is working with families and extended family members. I have had cases where the person hasn't been compatible with life, and I've spent time with extended family members and saying goodbye and working with them to cope with what's going on for them and their family. Yeah, absolutely. And a lot of the work I do is with families. Yeah, absolutely.
Yep.
When did the inappropriate advice contact psychology and non-appropriate? What's the example of that?
Yeah, suicidal ideation. So if a patient is saying they want to end their life or they have plans to end their life, if they're an inpatient, you would refer to consult liaison psychiatry and they would do a risk assessment and intervention. If they're outpatients as well, say you're an outpatient clinic and a patient is wanting to end their life, you could either send them to ED or if you can call to do an assessment before. Yeah.
Is that the same case?
Yeah, so there's actually no psychologist in ED. There are a lot of social workers who work in ED ED, who often do that assessment, and there is a psychiatrist. Yes, but unfortunately, psychology does not work in ED.
Sorry, I didn't catch that.
Sexual assault cases.
In ED, social work get involved in sexual assault cases for patients under 14 years old, so the children. Over 14 years old, it goes to the SAS team, so our community sexual assault team.
Is that how it works? Is the other one nurse before is the SAS team for council or health service?
Sorry, I didn't catch that either. Sorry.
Is the SAS team, is there one, so saying there's one nurse for Darling Downs only? Is there like one nurse in that SAS team, or is it a bigger team?
No, so the SAS team here in Townsville, my understanding, does not have a nurse. We have our own nurse here in the hospital that does that. She's the clinical forensic nurse. So the SAS team work with her. So they know her very well. When they turn up here, they get her and they work together. Yeah.
In your ED orientation, they will hopefully go through all that, but just make sure you clarify with them what is the process and everything like that. It may not be like a role for the intern at that stage,
Yeah.
but in saying that, it is still just make sure you feel, because it may not be something that is automatically, it may get divulged to you later once you're talking to a patient. So
if it's divulged at the triage phase, that SAS team is automatically activated, essentially.
yeah, go for it.
Just with like family members, I'm not sure like when we like psychology, do we have to, are they supposed to be enrolled in IEMR or like how does that work?
Sorry, so the question is, if you've got a family member that you're worried about, do they have to be already a patient in IEMR, or can you just contact social work or psychology to have a talk?
Yeah, that is kind of a very grey area. So when we're referring family members for support, where it's more in the context of referring them as family member because we want them to be able to cope because they're going to be supported of the patient. So it's still all in the context of the patient and the patient's well-being. So in terms of recording discussions with family members, it would be in terms of we've discussed this with a family member, provide a brief intervention, psychotherapy, support coping. It is something that is I've worked with parents who have primary mental health concerns that I've worked with them to try and be there for their child. I will go into the file and record sense information file. It does look a little bit blurry because it doesn't get recorded. It has to be I have two notes, but the note that gets recorded in the parent file doesn't get have that record. More for a safety precaution more than anything. Having that but there always be file that I have. So yeah, good question. So for the hospital, because we're part of the allied health group, we use IEMR. The mental health service group uses SIMA, but for somewhere like consultant based on psychiatry, where we're across both of those industries, we actually double up the notes.
So SIMA is a different computer program that mental health uses. You will learn that if you're doing a mental health rotation, that will be part of your orientation with them. But they also use some components of IEMR for things like medications and like that, I believe. Question that I've got, just with you were mentioning about working with the Indigenous health liaison officers. Can you give a little bit of a distinction between the workers, say a social worker or and with Indigenous health workers and when they might get involved?
Yeah, so the Indigenous health workers will definitely get involved with patients who are at high risk of dying or at high risk of not waiting to be seen.
Yep.
So an Indigenous health worker might get flagged as soon as a patient is in our waiting room, or if they're starting to become agitated or aggressive. Once they get triaged and brought in through to the acute side, then we will get involved as well. Or the ILOs might come to us and say, can you come and see this patient because they need some information on community supports, or they need to be linked in with something else in the community, something like that. But the ILOs definitely are flagged generally before us with their patients. Yeah.
Any questions for any of our panel members? We'll finish this one. No? Excellent. Thank you so much, guys. It's really great to have, as I've said at the outset, it's nice to have some faces to put to names when you're on the end of a phone. So no doubt you will be contacting the team here and their colleagues. But yeah, thank you very much. And I really appreciate participation. Great. Thank you. So guys, we're running, I'll just stop the recording, but we're running a little bit ahead of schedule. We've got about 2 minutes, so not that far ahead of schedule. I'll just grab the rest of my crew. I'll cut that out of the thing to